I hope it will be a fruitful webinar for all of us. Good evening, everyone. Today we will be talking about the motor intervention in children, motor development in children with Down syndrome, early intervention, and BMS method. You all know what Down syndrome is, but let me briefly mention it. We know that there are lots of genetic anomalies in the literature, and the most common one of them is Down syndrome, and the number of or the copies of your chromosomes should be 46, but if you have Down syndrome, you have 47 chromosomes. And when we look at the prevalence, we know that 1 out of 600 live births has Down syndrome. Sometimes it's up to say 800 or 700 or 800. So this is why I mentioned it in my slide. Let me briefly talk about the physical characteristics. They have almond eyes, and they have a small nasal bridge, but it doesn't cause any problem with the vision. They have a small and flattened nasal bridge, and they have low birth weight, and their fontanelles are a bit larger when they are first born, and they have brush-filled spots in their iris, and it doesn't have any negative effect on the vision, and their ears are at a lower level and smaller, and they have small ear and nasal ducts, and this is why they have ear infections or nasal infections very frequent. And this is why, in terms of such infections, they are at a risk group. They have protruding tongues, and they have small mouths, and we know that tongue is also a muscle, and when it's protruding, it might be a little bit problematic. But if you intervene at an early age, you can fix this problem. I have never seen any of my kids, any of my children with Down syndrome still having protruding tongues. Therefore, you can easily fix this issue. They have narrow palates, and they have short necks and wider back of the neck, and their skin is dry, and also it's rough, and they have straight hair, and they have soft hair. Their arms and legs are short, their fingers are short, they have wide palms, and they have stubby fingers, and the fifth finger, the little finger of their hands, is short and curved inward, and in their palms they have single line that is called Simian Line, and they are short in height. All these characteristics do not appear in every child with Down syndrome. You might have 5 of them, or you might have 3 of them, or you might have thought that my child has this characteristics but not that one. Here you see the Simian line in the palm. Instead of 2 lines, there is just 1 line that is called Simian line, and on the right hand side you can see a normal palm. Children with Down syndrome might have some health problems. You may think, why do we talk about the health problems right now in this presentation? But I can tell you that some of the health problems have a negative impact on the motor development of the child. This is why it is important to know about them, to diagnose them at an early stage, and to take necessary measures, and if needed, to go through necessary surgeries. This is why I wanted the health problems to be a part of my presentation. Children with Down syndrome, almost half of them have cardiac problems, heart problems. And we know that the heart has 4 chambers, and you know that there may be some problems with the valves, or there may be holes in the heart, in some chambers of the heart. This is why children with Down syndrome should be screened by a pediatric cardiologist for such problems. They are referred to pediatric cardiologists, and the doctors check whether they have such problems. Some of the issues with the heart can be solved spontaneously, but some children may require surgery. And if children require surgery for that, we see that these children are weaker and more lax. Their muscles are more lax. They may have some problems with digestion. Reflux is a problem. As a fecal reflux is one of the problems that is most commonly seen. And also we have other problems which are not so common, but there may be an anus problem, there may be some stenosis in their bowels, or there may be some problems with the esophagus of the child, structural problems I'm talking about. If there are any such problems, the child should be operated immediately. Therefore, you should go and find pediatric gastroenterologist to solve such problems. With regards to vision and problems with regarding vision, many of the children with Down syndrome may have visual problems. 3% of them have congenital cataract, and up to now, I have not seen any congenital cataract patient in my children with Down syndrome, but I have seen short-sightedness or far-sightedness in children with Down syndrome. There could be strabismus or nystagmus, that is the movement of the iris, and there could be cornea problems or eye inflammations, especially if the children has a very low level of immunity. They may have common inflammation in their eyes, and there may be some auditory problems. This is also very important. Why? Because it affects the mental development and also speech and language development of the child. And if you detect any such auditory problems, you should try to treat it immediately so that it will not cause any delay in speech. But if you have any problems with the hearing, then the speech may be delayed. So it's very important. And there could be congenital hearing problems, but in addition to this, there could be ear inflammation, and this may also lead to loss of hearing. And also there are problems related to the thyroid gland. Hypothyroidism or hyperthyroidism can be a problem. And these are problems that are common in children with Down syndrome. Most of the time we see hypothyroidism. I mean, there is lack of thyroid hormone in the child, so this should be detected at an early age and it should be treated. Otherwise, it may lead to some mental development problems. And other than that, we know that their immunity is not so strong, their immunity is weak. And this leads to the fact that children with Down syndrome get sick very frequently, and they're open to infections. And around 6 to 8% of children with Down syndrome may have seizures, and some of them have epilepsy, or some of them have West syndrome. But thank God, the prevalence of such problems, such issues is not so high. Let's talk about the motor development in children with Down syndrome. What are the problems or differences in children with Down syndrome regarding the motor development. We have three main problems here. These are the causes of the motor problems we see. First of all, they have hypotonia, their muscles are lax, and they have weakness of strength in their muscles, and then they have loose ligaments. Let's talk about them. Hypotonia, individuals with Down syndrome may have some deficiency in the development of their brains or neurological systems, and this hypotonia occurs since the beginning of life. Sometimes when you hold the baby, you feel that he or she is very relaxed, and it's all over the body. I mean, it affects the organs, all organs of the body, and this affects the movements of the baby and the development of the baby in a negative way, and this may lead to some movement problems in children with Down syndrome. This is why they try to sit in a way with their legs wide apart, wide open. This is why they want to have more support from the ground. I will show you some videos at the end of my presentation. And muscle weakness causes problems or causes delays in all areas. And the solution to this problem is physiotherapy for these children. All children with Down syndrome, at least until they manage to walk or they manage to climb the stairs, they should attend physiotherapy programs. We think it's appropriate for them to attend such programs. Gross motor, fine motors, chewing, and speech are all the areas that are affected by hypotonia. And as the child grows up and as they acquire new skills, the laxity of muscles is reduced but not totally gone. Let me talk about the muscle strength weakness or muscle weakness. Their muscles are not strong enough. This is why they use their organs less, and this causes problems with the body awareness, sensor deficiencies, lack of movement, and the lack of use of their arms and legs. And with this problem, the children tend to adopt compensatory movements, because children with Down syndrome want to move. They want to move, we know this. But although they want to move, there is laxity of muscles, there is also weakness of strength, and in order to deal with these problems, they find their own solutions and develop compensatory movements to overcome these problems they have. Let's talk about ligament laxity. Ligaments are there to connect two bones together so that they can help with the movement and keep the bones together. But if they have laxity, we know that bones move outside, move apart, and this may lead to hip dislocation. I mean, children with Down syndrome may have hip dislocation at early ages, and this is why they should be screened for hip dislocation at a very early age, which is done for all children when they are first born. And sometimes when the children have some such problems, they may be treated by a tool, by a device, instead of surgery. You don't have to have a surgery all the time, but you should detect it at a very early age. Otherwise, you may need to have surgery. I mean, your child may need to have surgery. And we also have general curvatum, which means the knees bending backwards. If your legs, if the legs of the child is not strong enough, the child cannot use the muscles, then uses the knees. And this actually locks the knees because they bend them backwards. And this causes problems with the ligaments as well. And if you do not prevent this bending backwards, backwards, this may be problematic for the child, for his or her walking. There is also for the atlantoaxial instability. What is this? Between the first and second spines we have in our neck, there might be a gap there, a larger gap there. I mean, vertebra. I'm talking about the first and second vertebra. There is a wide gap, and if the child jumps off the trampoline or tumbles down or does a somersault, this may be problematic, especially if the child has atlantoaxial instability. This is not so much common, but we should still be aware of it, because when the child is 5 years old, you should have an X-ray, and orthopedists can make the diagnosis and can make the necessary interventions regarding atlantoaxial instability. And you should avoid activities that may be problematic for the atlantoaxial instability, such as doing a somersault or something like that. But if your child does not have atlantoaxial instability, I mean, if there is no gap between the first and second vertebra on the neck, it's okay for your child to do a somersault. You should not prevent or hinder his or her activity. We also have patellar instability. That is the kneecap laxity, we can say, in other words, and this causes pain in children, and orthopedists recommend surgery if your child has patellar instability. And also we have the ankle inversion problem. This is the most common problem that is caused by ligament laxity. And if there is ankle inversion, then after necessary and appropriate assessment, your child can use orthesis or other supportive devices to help with this problem. Can I make a very brief recommendation? We have participants who are raising their hands, but we will not take questions until the end of your presentation. So I would like to ask them, please use the Q&A part, Q&A button to type your problems. We will save all your questions, and then we will ask your questions to Gönül Arısoy. And the same thing applies for the people who are watching us live on Facebook. You can type it in the comment section, and then we can read them and ask them.
A symbol of word. It's written interpretation. So if you click there, you need to choose English. We have a translation for English, so you can follow the presentation from there in language of English. Teşekkür ediyorum. Kusura bakmayınız. Buyurunuz.
Thank you so much. Go ahead, please. When we look at the main motor problems in children with Down syndrome, we know that they have problems in ensuring and maintaining balance. We can see it while sitting and while standing. And they have problems while forming their posture and maintaining their posture. Of course, posture is not just the body posture, but for instance, while carrying a tray, you should have a good posture so that you can carry that tray. And also they have some digestion problems because of the muscle laxity. They may have problems with their tongues or chewing muscles or swallowing muscles because they have hypotonia. And of course, it's not only about digestion, as I told you, it could be about the speech, but also it could be about respiration. So we may have some negative effects on speech and respiration as well. They have problems with the hand skills, fine motor skills, and they also have problems while weight bearing. When we're talking about BMS, I will be trying to explain this further. These are the reasons why we need physiotherapy in children with Down syndrome. These are the causes for it, and we can prevent these problems by physiotherapy, or we can at least reduce them by physiotherapy. How does a child with Down syndrome move? In researches, we see that these children act or move symmetrically. They move their arms or legs, both arms and legs, in a symmetrical way. They keep their body in the midline and they refrain from rotational movements because they cannot stabilize their postures. They move symmetrically in a stable manner and with lots of support. What do we mean by lots of support? They need support from their hands when they're sitting on the floor, or they may need someone else to hold up their bodies. So they need lots of support while moving. So if a child moves with lots of support and acts with a symmetrical and stable way, they cannot improve diversity of movement, and the rotational movement of the trunk does not develop, does not improve, asymmetrical movements does not develop, and they have problems with their balance. This is very important. Well, and they also lack postural control. For instance, while carrying a tray, they should keep their bodies active and they should keep their posture active, and they may lack this. And when they cannot these things, they develop compensatory movements. And let's say that they cannot feel independent, they cannot go outside to play with their friends if the child does not overcome these problems. Compensation or compensatory movements, these are the movements for children with Down syndrome, and they develop these movements. Why? They want to move, but they cannot move as they want, and instead of staying still, they develop compensatory movements, and these are caused by hypotonia, weakness of muscles, and laxity of ligaments. And we see that they develop compensatory movements that are unique to Down syndrome. We should know about them. Why? Because while assessing the child, they will be useful for us, and we know that these movements are unique to Down syndrome, specific to Down syndrome, and we can plan the next stage in an easier way. And these issues also cause some problems, some pain in the children as well. Compensatory movement is a different or new term for Turkish speaking participants. For instance, they rest their heads on their neck while sitting, or they sit in a way with their backs curved, or while standing up, they open their legs apart, or they in toe while standing, and they rotate with their whole body instead of using their trunk. So we understand that the children want to move, but instead of typically developing children, they cannot do it that way, and they develop compensatory movements instead of those. Let me show you babies with Down syndrome. Let's look at the figures. On the left-hand side, you see the spine position, prone position, and you see that we call this frog sleep. And if you leave a typically developing child like this on the floor, they would try to move their arms or legs, but the babies with Down syndrome lie like this, like a frog on the floor. And when we look at the figure in the middle, when you hold the child in a prone position while holding the trunk, you see that the arms and legs are going downwards, and it feels like as if the child would slip down from your fingers, from your hands. And the third one is if you hold the child with your hands, and when you pull the body, you see that the body comes up, but the head goes backwards. And I will show you some videos about these movements. Let's look at the sitting posture of children with Down syndrome. On the top left, you see the child sitting on the floor with legs wide apart. They need support from the floor. This is why they put their legs apart and they put their hands on the floor. On the right, top right, you can see the back is curved and the arms again on the feet, supported by the feet. And in all these figures, drawings, the hands are somewhere for them to get some support. So we told that these children get lots of support for their movements. And here you see these drawings again, the same thing. And here on the bottom left figure, you see the legs are very wide apart, and the fourth figure is the head resting on the back of the neck. And if you do not intervene in this position, the child would put the head in this position while walking or while standing up when he or she grows up. Here you see 3 photographs. You can see on the left hand side with the back sitting with the back in a curved position, and the head is resting on the neck. This is why the finger is lifting the head up. In the middle, you can see the child is supported from the trunk, and you can see how he or she sits straight up. So if you do not support from the trunk, the back would be curved, and on the right hand side you can see the straight sitting of the child without any support and sitting independently. Children with Down syndrome who has recently started walking. On the top side, you can see a child crawling here on the top left, but please pay attention. While crawling, this child's hip is not high enough. I mean, the hip is not at a high level for crawling, and the hip is at a lower level than necessary, and this is caused by lack of postural control, lack of strength of muscles. And in this position, they just use their legs, dragging their legs, and this is not something we want in the future. On the right hand side, you can see a child who is walking, but the legs are wide apart. The arms are up in the air, and this is how they walk. This is a specific pattern for Down syndrome. At the bottom, you can see a child who is trying to stand up and using his arms to stand up, and he needs more time to stand up without any support. And in the fourth one, we see this in children with Down syndrome. That is the position that that the child is in prone position and goes up to sitting position from this prone position. And this is unique to Down syndrome. It's only it's the movement you can only see with children with Down syndrome. And here you see three pictures. On the left part, you can see the child is standing up, but the knees are bending backwards. You can see, and the ankles are a bit inverted. So the legs and muscles of the legs are not strong enough yet. And the second one is the second picture belongs to the same child, and now we can see the improvement. Her knees are much better. And the third one is a boy with Down syndrome who can walk without any problems. So what are the benefits of movement in child's life? It has lots of benefits. They are integrated into daily life and they can learn in a faster manner, and they are included in the society at an earlier age, and his or her posture, balance, coordination, and muscle strength improves. He or she can jump and runs and climbs up and down the stairs, cycles, and plays ball. And the child will become more independent, and they can play more games, and they can have better skills in self-care, and also the weight gain problem is prevented. And we know that there is less risk for heart or respiratory problems, which is an important issue for children with Down syndrome. What are early intervention programs? These are the programs used for early intervention in early childhood. And in this program, you inform the family, and that program is based on supporting the child and family. And this program can be maintained at home or at some special institutions. And we know that although it's debatable, for young children, we use such programs at an earlier age right now. And the child should be around 1 month old to make the necessary diagnosis for this. And health, nutrition, or other issues can be dealt with early intervention. And the first 3 years of life are very important for all children, and we call this as the golden age of development. And the first year of life is very important, and then comes the second and third year of life. Of course, the first 5 years or 7 years are very important, but the first 3 years of life are golden ages of development. And why are they important? Because the neurological system improves and develops at a very fast manner between the ages 0 and 3. And diagnosis should be made at an early age, and this will help the family to receive developmental and education services. And for the 0 to 3 years of age, we have early intervention programs. And in this program, we have the targets and the requirements of the family and the child. And between 3 to 5 years of age, it is the preschool period, let's say, and for 5 or 6 years, it's the kindergarten period, that is the before the school. So when should we start early intervention programs? As early as possible. Sometimes it's said that you should wait for 2 years or 3 years or 5 years of age, but this is not the case. The first 3 years are very important, and you should have very useful time in that period. When we look at the benefits of these programs, we know that it has benefits for the child, for the family, and for the society. From the child's perspective, we know that the developmental areas are supported by early intervention programs, and the secondary problems are prevented by these programs. And you may need less support from special education in the school period, and there will be improvement in independence of the child. And we know that the family interaction is improved, and the stress levels of the parents is reduced, and the parenting skills of the parents are affected in a positive way, because they would know what they should do. And when we look at the society, if you use the early intervention programs, there will be less need or little need for special education in later years of life. Of course, the cognitive, fine and gross motor skills, social skills, emotional skills, and self-care are all the areas that are supported by the early intervention programs. And the interactional behaviors of the parents are supported, and they will have a positive effect on the interaction between the parents and the child. And also the families know how to intervene, and this way you will have less problem behaviors in children. And when you look at the researches, we see that there are very many benefits of these programs in children with Down syndrome. And we know that the studies show that there is an improvement in the cognitive skills and cognitive scores of these children, and the other in other areas as well. What are the professions included in the early intervention team? First of all, family should be there. I mean, families should participate in early intervention programs. They should share their expectations and their complaints and their desires. And then we have the doctors that make the diagnosis. They should be included in this team. They could be child development specialists or developmental pediatricians or neurologists and etc. And depending on the requirements of the child, there could be dentists or audiologists or cardiologists or other specialties can be involved in this team. With regards to motor development, physiotherapists are very important. With regards to fine motor or sensory development, occupational therapists are very important. Special education specialists are very important. Speech and language therapists, and also preschool teachers and child development specialists, counselors, audiologists, and specialists for orthesis or prosthesis. There could be many professions, many people from different professions included in this team. BMS, Basic Motor Skills. BMS is the acronym for the Basic Motor Skills. And these are the basic motor skills in children with Down syndrome. This is a method used for children with Down syndrome. I will give you some information about this method. And BMS is actually methods that evaluate the motor skills of children with the Down syndrome in a functional manner. And as a result of these assessments, we develop the physiotherapy program and the targets for the child. So when you assess the child with PMS, you can find out what your child can do, what your child cannot do, and what your targets should be. PMS is used in different countries of the world. It is developed as part of an international project, and it originates from Netherlands, and now it's used Ukraine, Bulgaria, Russia, Switzerland, Belgium, America, Sri Lanka, Indonesia, Turkey, and Romania. And in Turkey, we have 3-day courses on BMS, and mostly physiotherapists or other professionals from different areas can attend these courses, these 3-day courses. And in Antalya, Istanbul, Ankara, Rize, Gaziantep, İzmir, and Diyarbakır, we organize these courses. We have 3 licensed physiotherapists for BMS, and we're still being trained on this. I live in Ankara, Gönül Arısoy, this is me. And from Rize, we have Filiz Bayraktaroğlu, and from Netherlands, we have Jacqueline Clara Altan. We are 3 physiotherapists from Turkey, and we give the courses, and this is a photo of 3 of us. Now, let me talk about what BMS means. BMS was described by Dutch physiotherapist Peter Lotuslager, and he used this method in his PhD thesis, and he collected all the data and published books on these data. And you can also have the Turkish version of this book from the website of the Turkish Society of Down Syndrome. This is a assessment method and treatment method developed specifically for children with Down syndrome. Why is it specific to children with Down syndrome? Because most of the assessments we used up to now were the ones that were developed for typically developing children or cerebral palsy children, spastic children. Therefore, for the children with Down syndrome, you may miss the compensatory movements that are unique to Down syndrome with the other measurement methods. This is why the scoring is not so good in children with Down syndrome if you use other methods of measuring, because we have some subscales that are unique for Down syndrome. And BMS measures the child from birth until they walk, and it's said that is for children between age 0 months up to 36 months, but you can use it up to 4 months, 4 years, or 5 years. And we know that this method identifies the postural control problems of children with Down syndrome, and it's a reliable and valid measurement method. It gives us an idea about the motor development of the child, of the individual child, and it helps us to find out about the therapy targets for that child, and it also helps us score the child as child's motor behavior specific to Down syndrome. I mean, you can assess the child with BMS and you can compare the development of the child with other children and also the child's own development when compared to the past. Of course, I don't mean to compare this child to another child. We should never compare our children with other children, but I'm talking about the Down syndrome specific figures. We can use these figures to find the benchmark for our child. We have 15 items in BMS. It starts from the spine position and goes up to skills like raising legs in spine position, reaching with arms in spine position, rolling over from prone to spine or from spine to prone, and then comes sitting, moving along the ground, walking with support, standing up with support, standing without support, and walking without support, and standing up without support. These are the items assessed in BMS. Now, let me show you the postural control while sitting. This is the test item 7. Let's look at this figure. In the first one, the child gets support from the floor. You can see the back is curved. And you score, you just give 1 point if the child keeps this posture for 5 minutes. The second one is the child sits independently for at least 5 seconds while supporting the position with one hand, then you give 2 points. And if the child sits independently for at least 2 seconds without support from the arms and with a bent back, you give 3 points. The child sits independently for at least 2 seconds without support from the arms with a straight back without lumbar lordosis, then you give 4 points. If this is the case, this is harder, this is close to a normal posture. And if the child sits independently without support from the arms, you give 5 points. And if the child sits independently without support from the arms again, you give 6 points. So you see that typically developing children can only sit with arms supported by the floor or without this support, but we have some subscales here. And here, looking at these items, we give some points, some scores, and you get a score. For instance, let's say that the child is 36 weeks old and the child's score is 13. So it is less than 14, which is the required score for this age. So we understand that there is a little bit of delay in this child. But if the child scored 16 when he is 39 weeks old, we could say that this child's development is going well, is going ahead. You see the figures here. These are the figures, the data from children with Down syndrome, only children with Down syndrome, not typically developing children. So while we are checking the developmental status of our children, we are acting in a very fair manner because we see that all these data are from children with Down syndrome. This is Zeynep, 2.5 years old. 2.5 years old. This is how she lies down. You see the legs are wide apart. One of the legs is raised. Not both of them are raised, but while raising the legs, you can see she needs support to raise her legs, and you can see her rolling is not too bad, a bit primitive, but she can roll. That's a good thing. And you can see the legs are wide apart, so she gets support from a wide area, and she cannot keep the legs in the midline. That shows us that there is some lack of strength in the legs.
Evet. Yine aynı çocuğumuz,
This is the same child, same girl, sitting. She's sitting. She has a nice sitting position. We cannot see her back, whether she has a bent back or curved back, but her legs are wide apart and she can rotate backwards to take the train. And this is a very important movement, actually. She can rotate, and rotation is a very important skill to improve your movement quality. This is Zeynep again, the same girl. Here, you can see she is bear walking. She is bear walking here. She's walking like a bear with her hands on the floor. And this movement is just 0 points, but in BMS, we know that the child is now able to change place and move her body. We assess it and we give some points as well. You see the knees are bending backwards, but this is the way of crawling the child prefers. It's not always very common, but we sometimes see this in children with Down syndrome.
Evet. Şimdi size Rosemary'den bahsedeceğim. 10 aylık bir bebek, Down sendromlu.
This is Rosemary, 10 months old. She has cardiac problems, severe cardiac problems and organ problems, and because of hypotonia, she cannot be fed from the mouth. This is why she is fed, she is nasally fed. And this is the physiotherapist, Peter Lautersliger. You can see how he works with the child and how he assesses the child. Please look at the arms and legs. You can see Peter is trying to hold arms, but you can see how much the head lifts up from the floor. The head is not raising, is not lifting up at all. The same child, the same girl, Rosemary. Peter holds her in his lap, and he can see his arms and legs, and the child who cannot lift his head now, with the good positioning, we can see that her arms are moving very well. She can move her arms trying to reach out to the toy, and she holds the toy. It's very important for the child to reach out to an object and to hold it and to rattle it. These are very important skills. And again, he brings the toy close to her and she holds the toy, but now he is positioning the girl to keep the toy in the midline. He is helping the girl to hold the toy with both hands.
Şimdi o biraz önce başını tutamayan çocuğu
You can see that with the good positioning, she can hold up her head. You can see that in future videos in a few seconds. She can hold up her head in a better way. When in the midline, she can hold her head in balance. This is very important for head control. And let's look at the girl who could not raise her leg a couple of minutes ago. Remember, her legs were on the floor. Let's see if Peter could help her raise her legs. Peter is giving some stimulants from the legs, and you can see her legs are up. She can raise her legs. Very good. Well done. It's very important for the child to raise her legs. It's very important for her sensory skills to develop. This will help her improve her body awareness and vestibular systems. So many things are included in this area. And these are the initial basic movements. You know that the children like to hold their feet and bring them to their mouths, and they suck their toes. They like it. And this is the way how Peter helps her do this. Let's see if she could do it again, raise her legs again. Yes, she raised her legs. When you keep the baby in your lap like this and give the right position, you can see the right movements coming from the child. And this is the same girl, Rosemarine, again. In the right position in the lap, you can see she can hold her head. Although it's a bit slanted, it's a bit downwards, but it's okay. She can hold her head.
Biraz kaldırıyor, biraz bırakıyor, biraz kaldırıyor, biraz bırakıyor. Böyle
Sometimes
değil.
she keeps it straight, and sometimes she keeps and rotates her head, but this is the way how it will look.
Evet, babası, çocuğun babası oyuncağı aşağı yukarı hareket
You can see the daddy moves the toy up and down and helps the child look at the toy, and this is a very good skill to develop because it helps the child to move her head. This is Rosemarine, 5 years old. Now you will see how she looks like. This is bear walking again. She's bear walking, 5 years old, and she stood up with support from the floor by her hands, and the knees are bent backwards because her legs are not strong enough, and this is how she locks the bones. And she has taken 10-12 steps, and we applaud her as well because she has lots of health problems, and we really admire her. This is the end of my presentation. Now I believe we can take the questions. Thank you very much for your presentation.
Ben şunu anladım, eğer bir hatam varsa yanlış
please correct me if I'm wrong, but what I understand is that with the BMS, we can have a special assessment for children with Down syndrome, and this is a way of measurement for assessing children with Down syndrome, and we can find out the areas of intervention in a better way with this method. What I would like to ask is that while receiving physiotherapy support, the families may ask their physiotherapist whether they have been trained on BMS. Would it be useful? Sure. We have the BMS method courses. We have theoretical information and practical information in these courses. And then at the end of the course, we have an examination. And once you pass the examination, you will have the right to use or to apply the BMS method. Of course, what we want from the families is that they should actually have a physiotherapist who knows about BMS, because sometimes we see that there are inappropriate interventions. For instance, the child is given passive movement, but passive movement is not always so good for the child. It helps the parents to get better muscles, not the child. So they should work with physiotherapists who know how to do this and who have been trained on BMS. And also, I would like to ask something else. They assess the child with BMS after they have taken the course, but they also know how they should support the child with the BA methods in BMS. Yes, at the end of this course, the physiotherapists know how to assess the child and how to report the child's skills at the end of the assessment, child status, and what the child's targets should be for physiotherapy. What are the recommendations they should give to the family? And the most important thing here is that they should support, the families should support their child after physiotherapy. Now, with your permission, I would like to ask some questions typed in the Q&A box. My son is 6 months old and she cannot hold his head, his neck. What do you recommend? What kind of movements do you recommend? Of course, we cannot recommend some movements, but a child that is 6 months old should start physiotherapy. All children with Down syndrome should work with physiotherapists. As you can see in Peter's videos, you can bring the head of the child in the midline and position the child in the right way so that she or he can hold the head. You remember that Peter puts the child in spine position and prone position and sitting position, and prone is sometimes missed because it's very important to help the child move his or her head in prone position. You can use some toys. You can put some toys in front of the child and help the child move his or her head. Next question. Hello, my son started physiotherapy when he was 2 months old, and we went on for 7 months, and we had a trauma because of the therapist, and we had 3 months of leave, but my son does not want to go to physiotherapy. He is now 1 year old. He can sit and he can walk independently. He can stand by a coach and he can eat while sitting, and he can say, "Mommy, Daddy, grandpa," and etc. And we started special education. She can do everything at home, but he doesn't want to do anything there when we go for physiotherapy, and the rehabilitation center does not help with this and does not cooperate with us. Of course, we do not want the child to cry while doing this. If the child has developed such a reaction, this is not something we want. Therefore, they should either change the physiotherapy method they use. They should play some games with the child. This is how we start.
Çocuk nesnelerle oynarken
We start by playing games, and while playing games, we give him the exercises, we do the exercises. Maybe they can change the rehabilitation center they go to, but you said that the child can stand up and can say a couple of words. This is a good sign for his development. But we know that the children with Down syndrome sometimes can be stubborn. So we should take it into consideration as well.
1 yaşında zannedersem uygun bir kurum
The
eğitmen.
child is 1 year old. I believe they should continue physiotherapy if they find the right center to help the child. I mean, until climbing up and down the stairs, we recommend children to continue physiotherapy. Thank you for the presentation. Should we prevent compensatory movements or should we support them? What should be the perspective if we see the compensatory movements? For instance, the resting of the head on the neck. This is how they do it. Look at me. And you should not support this. I mean, you should bring the head into the midline, and we do not want the child to put their head back on their neck. We don't want this.
istiyoruz. Dizin geriye kaçması dedik mesela.
We want the child to walk with their legs close to one another. We don't want their knees bent backwards. This is not a good thing as well, and this may cause pain when the child grows up. So when we see the compensatory movements, these are the movements that we expect, but we do not want them to occur, so we should prevent them if possible. You said in your presentation that in children who are encouraged to walk, they may bend their knees backwards. So is this something important to find out whether the child is ready to walk or not? Because sometimes families or parents want their children they want to see their children walk, and we encourage them to walk maybe at an earlier age than they are supposed to do so. So if the child has not completed the developmental stages and is forced to do a movement that is beyond her skills, then it could be problematic. The knees may bend backwards.
Dizlerini hafif bir miktar bükük tutmasına çalışacağız.
Of course, we can encourage them, but we must encourage them in the appropriate way. For instance, they can pick up an object from the floor, and we can help their knees if the knees are bent backwards. And the children learn about these, so we should be patient and repeat these supports. Next question. My baby is 10 months old. She is not sitting yet. She receives physiotherapy. What can I do? She eats, but she does not gain weight. What can I do? Let me start from the second part. With regards to weight gain, I cannot say anything because it's not my specialty. But a child that is 10 months old should be sitting, at least with support. You should be supporting her with cushions and put her arms on the knees and support the trunk with cushions, and you can help her sit like this, and she will be able to sit. And there is no baby with Down syndrome who cannot sit. They will be able to sit. Please work on it. How can I attend the trainings in Istanbul? She asks. I don't know whether she is a physiotherapist or a specialist in this field. This is not a training for families, right? Yes, you're right. This is a training for specialists and physiotherapists. We will have a training in Sakarya.
3 günlük eğitimin sonrasında ailelerin
At the
de
end of 3-day training, we have a meeting or a seminar where families attend as well, but we haven't organized a training for families. We only have meetings, informative meetings for families. So if you're a specialist, you can attend the training in Sakarya that will be organized soon. If you are a family, you can find a physiotherapist who is trained in this area, and you can contact with the Turkish Society of Down Syndrome, and we can also help families how they will find a physiotherapist trained on BMS. My child is 6.5 months old, and she doesn't bend her knees. She has some cardiac problems. She has just gone through surgery, and she hasn't received any physiotherapy yet. Cardiac surgery is a very important surgery, and you should wait for 2 months before you start physiotherapy after cardiac surgery, and they feel tired, and these children may have low immunity, and the children with cardiac problems may not be so willing to move, and they have overgone the important side because the important part because they have overgone the surgery, and I believe the child will overcome this problem, but we should wait for 2 months, and after 2 months you can start physiotherapy, especially children who have undergone cardiac problems or cardiac surgeries. We highly recommend those children to take physiotherapy, but they should wait for 2 months after the surgery. Until when should we continue with physiotherapy for a child with Down syndrome? I mean, my child can climb up and down the stairs, and she can walk. This is a very good thing. I would like to congratulate the baby and the family because she is walking at 2.5 years of age. Of course, while climbing up and down the stairs, we should know how she climbs. I mean, with support, without support, I believe she can climb down and up with support from hands. If your child is compliant, you can continue the physiotherapy, and you can try to jump over obstacles, and you can climb and up and down the chairs if you like. But I believe you should continue a little bit more for this child and then stop physiotherapy. Many families would like to thank you. In the comments, we have these. Let me continue. Our child is 3 months old, and when she will be 6 months old, we will receive support from a physiotherapist, and we were told that we should wait until 6 months. And should we wait, or should we find a physiotherapist? I answered this question, but let me repeat it. Maybe they have joined later in the webinar. The moment your child is diagnosed with Down syndrome, you should start physiotherapy, and the children with Down syndrome are diagnosed when they're 1 month old or 2 months old, and we give the right positions, we give the right support for these children as early as 1 or 2 months old, and we have some basic skills, and we should start with the basic skills and then build on the further skills. We should give a good frame work or good ground work for this child. So they should find a place for this child where they can find appropriate physiotherapy for a child that is 2 months old. And my child is 1.5 years old. And when we go to physiotherapy, she is not willing and to move. What could be the reason for this? Sometimes
biraz önceki ailedeki gibi başka bir uzmana, başka bir
children
birine, yani ailesinden başka birine
may be
katılmakta tereddüt
unwilling
ediyor, gösteriyor.
to move when there's someone they do not know, when there's someone who is not familiar, when there's someone who are not from their family. But the important thing is that if your child is walking at home, it's good. If your child was working doing physiotherapy but not at home, this would be a problem. But you say that your child is moving and trying to walk at home, this is a good thing. I mean, we have children with Down syndrome. They are not walking when they're with me, but they're walking at home. But don't worry, they will achieve it. My child is 17 months old. We are using cars with wheels. Do you mean the walkers for children? Because we do not recommend walkers or baby walkers for children with Down syndrome, but we also some different types of bicycles that the child should use the legs. This is useful. There are also bicycles or cars that requires the child move the legs. This is also helpful. I don't want to mislead you, so I need some more details to help with this question, to give an answer to the My baby is 17 months old. She is not crawling at all. We only have 4 sessions of physiotherapy provided by the state, and the prices of physiotherapy are very high. We're trying to support the child at home, but this is not enough. What is your recommendation at this point? Yes, you're right. Physiotherapy support is needed at a very early age, and it is limited, unfortunately, and the family should support the children themselves at home as well. What can they do? For a child that is 17 months old, sitting is a good thing. We expect a child to sit at 17 months old. And crawling is something, is a skill that we expect to develop. And we want the children to crawl. It's an important skill. And you can help the child crawl by using linen, maybe, or you can use other methods to help the child, to put the child in the right position, and you can play with toys while in crawling position. If the child is not able to acquire the skill, there may be something missing. There may be a lack of efficiency in previous skills, so it should be supported. Thank you. Last two questions are not about motor development, but maybe you would like to answer it. The question is that, is it possible for children with Down syndrome who receive a good training and education between the ages 0 to 3 and with a good education after 3 years of age, can they go to mainstream schools? Is it possible? What do you think about motor development in this respect? Of course, every child is a different case. I mean, we do not have unique children or the same children with Down syndrome, and the two children with Down syndrome are not the same. I mean, if the child is able to climb up and down and walk and potty trained at the age of 3 years, or if the child has some good social skills, then we would like this child to be with his or her peers at a mainstream kindergarten or preschool. If the child is ready for this, it will be really good for the child. So for each developmental area, it is good for the child to be with his or her peers. It could be good for the motor development skills or other skills, cognitive skills. Inclusion is very important. We always recommend it. There's another question. Why don't you recommend walkers? Can you give us some information about that? Walkers or baby walkers are not recommended. Why? Because for boys, it puts some weight on the testicles, and this causes problems in the development of testicles. This is not in my area. This is something beyond my area. But we know that with the baby walkers, you do not put the ligaments of the child on the floor in the right way. And while using a baby walker, we know that this may cause an introversion problem, and this is why we do not recommend it. And the child pushes himself or herself to the front, and this actually delays independent walking of the child. This is why we don't recommend it. There's another question. This is about the language development. Let me ask it to you. My son is 4 years old and he can climb up and down the stairs. He can walk since 2 years old, and he can only use single syllables or double syllables while speaking. What should we do from now on? Of course, you should go to a speech and language therapist for this. This is not my area. This is beyond my area. It will not be ethical for me to answer this question, but when we look at the child, her walking skill, his walking skills are very good because she could walk at the age of 2, but you should go to a speech and language therapist to improve the speech. It's not my area. Sorry for that.
Çok özür dilerim. Zannedersem daha önce yazan ailelerimizden bir tanesi sorusuna istinaden devam ediyor.
This is the second part of a previous question. Should we stop physiotherapy, you said that you should continue. For instance, we should jump from the obstacles, climbing up and down the chairs. What else we can ask for? We have the obstacles, wooden obstacles, and they can jump over these obstacles, and it's a very good thing because while they can do this, it's a good thing. They should do it because while walking outside in the street, they can overcome the obstacles they face. So there could be some small chairs that can be used, 15 minutes or 20 minutes. You should first support the child, of course, while climbing up and down the chairs. This is an important skill. They can work on it.
Benim aklıma şöyle bir şey de geldi. Onu da yönlendireyim sizlere. Özellikle bu sürece gelmiş çocuklarımızda
Especially for children who can walk and who can overcome the obstacles while walking. We know that there are some areas that have some tracks or lanes with obstacles. I believe they can use these tracks or lanes so that it will be like a game and it will support the child in terms of motor skills. They can use the chairs at home, they can make tents, for instance, under the tables. They can create some small corridors, and this is very important in terms of sensory development. Such activities will be useful for motor development and body awareness of the child. And I will not go into details of the balance systems or vestibular system, but such activities will help those systems as well. Thank you very much for the presentation. Our baby is 23 months old and she can walk, but she can move from one room to another, although she has difficulty while standing up. Why am I telling this? The baby was crying so much when she was 1 year old, and she overcame this, and it was really beneficial. We kept on. This is why I told it, especially I wanted to make a contribution, so the child will overcome its traumas. Our girl is 10 months old. Her development is good, but her legs are very flexible, and she can hold her feet, and should we intervene her flexibility, and how can we support the child? The children with Down syndrome have ligament laxity, and this is why they can flex their legs and feet, arms. This is not something we want all the time, because especially after puberty, this may cause some pain in the hips or in the knees or in the ankles. This is not something we want. So what should we do? You can use the pants and sew the pants to one another so that she or he cannot put the legs very wide apart, or you can use the t-shirts of the child, and you can keep the legs together.
Pantolonun dikilmesi güzel.
Sewing the pajamas or pants is a very important thing. You can try it. I forgot the name, but okay, I'll remember it. You use something the device or apparatus to keep the legs together. It's a kind of clothing. You can put the legs, I mean both legs in rompers or overalls. Yes, while walking they can use it. I don't know whether they use it while sleeping, but sleep is a time when our body and our brain are resting, and we do not recommend activities or hints or tips that will impair your sleep quality. Maybe you can use some cushions, pillows, so that can prevent the legs going far apart from each other. You can intervene whenever you see it, but I believe one of the most appropriate methods is to sew the pants together, two legs of the pants together, so that they could be kept together. We have run out of time, but we have 4 questions. Is it okay if I can ask them? Thank you very much. The participants would like to express their gratitude to you. My son is 4.5 years old, and he had cardiac surgery and also kidney surgery, and he had surgery for this hip dislocation. He's 4.5 years old. He's trying to walk with baby walker. He can stand up with support from the wall, and he can stand up without support for 3 seconds. We are a bit impatient, but we would like to get your recommendations about this child. Actually, first of all, I'd like to express my sympathies to you because you have undergone lots of surgeries, 2 cardiac surgeries, kidney surgery, the hip dislocation surgery. So the child has gone through lots of surgeries, and after each surgery, we expect the child to go backwards. I mean, the child has, let's say, lots of mountains in front of him. It's a good thing that the child can stand up. I understand that you are a bit impatient and you want to see your child walk, but remember that your child has gone through lots of surgeries, and it's something we expect when the child goes backwards in their skills if they have a surgery. So keep going, and you should try to keep the child standing up as long as he can, and you can help the child stand up with support from the wall, and you can help the child walk between the coaches. But there could be different activities such as tracks and other activities you can do for this child. And they said that he is trying to use a baby walker. Should they stop using them? What do you recommend? What do you mean by baby walker? I mean, we have medical walkers, but also we have baby walkers. Which one is that they are using? We don't know that. Is it a baby walker or a medical walker? Let's explain them. Baby walker is very well known. You know, you put the child in the baby walker, and it has wheels, and this is not recommended, right? Yes. It's not recommended for typically developing children either. The medical walker
bir şey. Hem düz
is something we use. This can be used by children with Down syndrome, especially when they need support while walking. They can push the medical walker and they can walk with that. So we recommend the medical one. So we made a distinction between the medical one and baby walker, and I hope it helped.
Evet, oğlum 25 aylık, 2 kere açık kalp ameliyatı oldu. Emekleyerek her yere gitti.
My son is 25 months old. He had cardiac surgeries. He can crawl, but his ankles are introverted. How can we support them? It's good that the child is crawling. With the introversion of the feet, we should assess it. You didn't say anything about standing up. No, it wasn't that. Let me go again. If there is in-toeing, you can go to an orthosis specialist and you can use an AFO for the child maybe, but it will be useful while the child is standing up. While crawling, you should correct the movement and warn the child verbally. It's not a baby walker. They say, okay, it's not a baby walker. If it's not a baby walker, it's a good thing. My child is 5 months old, and we started special education because his physical movements are good. Is it okay to start a special education as early as this?
Biz dedik ki tanı konur konmaz çocuk.
The moment you get your diagnosis, you should start physiotherapy, and you should also start special education. I mean, a 1 month old baby can receive special education. It's okay. And every skill we have is based on lots of mini skills. And without these mini skills, you cannot be successful when it comes when the time comes to go to school. So you should build on these mini skills so you can start special education as early as possible. 5.5 months old, the child cannot feel safe to cycle. Cycling is an important thing and supports the child as well. And the child, I mean the family wants to child to cycle, but do you know, is there anything special to use cycling? Is there anything special to do about cycling? There could be older children than your child, and your child can watch them while they cycle, the others cycle. They will not first sit on the bicycle, and you should first convince him or her to sit on the bicycle, and then you should have the feet on the pedals stable. For instance, one of the parents are just stabilize the bicycle, and they're just trying to pedal. This could be an option. And cycling is very important for social skills and for motor skills, for speech and language. Why? What does it have to do with the speech and language? Because with the bicycle, he will be able to interact with other children who have bicycles, for instance.
Kullanmak üzere biraz daha yaş ilerledikçe
as the children grow up, there was a place in another country, and they use cylinder wheels for the bike at the beginning, and then they make them small, and use smaller wheels and help the child develop cycling skills. So you can use larger wheels first, and then you can make them smaller, and this way you can help the child cycle. This is a very good contribution. Thank you. Thank you very much. We have been a bit late, but we did our best to answer all the questions that was received. I'd like to thank all the participants for being with us. I hope it has been useful for you. I would like to thank Gönül Arısoy for being with us and for sharing this valuable information with us. Thank you. Thank you. I hope to see you again